Good afternoon. These are our disclosures. The AUA and SUFU guidelines state that preoperative urodynamic testing may be omitted in healthy females who have not undergone a prior SUI procedure. This recommendation is largely based off of the data reported from the 2012 Value of Urodynamic Evaluation trial. We sought to investigate the trend in urodynamic testing in those patients undergoing a stress urinary incontinence procedure before and after the publication of the Value trial. Using the Dartmouth Institute's Atlas Rate Generator, exploring 100% of Medicare claims data, we identified females with a diagnosis of stress urinary incontinence by ICD-9 code and a CPT code for either urethral bulking or urethral sling procedure within 306 predefined hospital referral regions. We then identified the proportion of those who also had a CPT code for urodynamics within 1 year prior to their stress urinary incontinence procedure. The national percentage of preoperative urodynamic testing was 53% in 2011 compared to 55% in 2013 after the publication of the Value trial. In 2011, the highest rate of urodynamic testing was performed in Monroe, Louisiana, and the lowest in Jonesboro, Arkansas. In 2013, the highest rate was in Longview, Texas, and the lowest in Springfield, Missouri. So here you can see the geographic variation at the hospital referral region level in 2011 compared to 2013, with the darker areas representing higher rates of preoperative testing, the darker meaning the 50% or more increased. So taken all together, 52% of hospital referral regions actually increased their urodynamic testing prior to a stress urinary incontinence procedure, and only 40% of HHRs decreased their use of urodynamics testing. So in conclusion, there is significant regional variation in the utilization of preoperative urodynamics testing prior to stress urinary incontinence procedure, and this did not change dramatically before and after the publication of the Value trial. In fact, a large proportion of hospital referral regions actually increased their rates between 2011 and 2013. Thank you.
Can you just remind us, in the Value trial, were the patients asked what they thought about potentially having additional information that they would get from urodynamics prior to the surgery?
Yes, if they were asked that, if they had an opinion on getting the urodynamics testing beforehand?
Yeah, did patients value it? There's a study from Birmingham, a small study from Birmingham, in which women were told what urodynamics potentially would offer, and most of them said they would like to have urodynamics.
Yeah.
Were similar questions asked in the Value study?
I do not recall that question being asked in the Value study.
It might be quite important, mightn't it? Because I think one of the attitudes many of us take is that only by doing urodynamics can you give full consent, fully informed consent about how bad the urethral function is, whether there's detrusor overactivity, which might complicate things, that the patient actually has stress incontinence, and then finally, do they have detrusor underactivity, which might still not give them a particularly good stream and may have a bigger residual urine. Does that ring a bell with this 50% of urologists and gynecologists who are doing the tests?
It could. And again, in our population, this is all Medicare patients who are older and may not be the index patient that the guidelines refer to.
Right.
But we thought that by comparing the 2 years, that there'd be about the same number of index patients between 2011 and 2013, so you still would expect to see a decrease, perhaps.
Right. Yeah, thank you.
In light of even Dr. Razier's paper today on quality of urodynamics, was there any quality control within that Value trial, and who was doing the valuation on the actual quality of the urodynamics?
Well, was it not very good then? Quality.
I believe there was standardization, but I'm not sure about specific quality control.
While I didn't participate in that, I can briefly speak to the fact there was rigorous quality control in that particular trial, within the framework of that particular trial.
Marianne Harvey from Canada. This is a very nice study. Thank you very much. Acknowledging that we are all a little bit slow to adopt change, could you tell me why you picked the year after as opposed to, say, 2 or 3 years later, because change takes time?
Mm-hmm. Certainly. It's basically the availability of the data that we had. Certainly, if we go on, other years become available, we may be able to see a trend in change. And there have been several publications that show that even after the publication of guidelines from certain bodies, it takes at least 10 years to see any significant change in practice.
Thank you.
Excellent.
Thank you very much.
Thank you.